Good day, ladies and gentlemen, and welcome to the SPSP Medicines Reducing Medicines Harm Across Transitions conference call hosted by David Maxwell. My name is Kate and I'm your event manager. During the presentation, your lines will remain on listen only. If you require assistance at any time, please key *0 on your telephone and a coordinator will be happy to assist you. You may submit web questions through the chat feature on the WebEx, and these will be addressed in the Q&A session. I would like to advise all parties this conference is being recorded for replay purposes, and now I'd like to hand over to David. Please go ahead.
Thank you very much, Kate, and welcome everybody. It's great to have you along. This is our 10th and I guess final WebEx for 2016. However, we want to stress that the WebEx series is continuing through. Our current series is due to end at the end of our current financial year, which is going to be March 2017. But it's absolutely fantastic that we've got colleagues from NHS Lothian sharing their experience this afternoon. So again, a very, very strong, warm welcome. We'd like to welcome two others that may be joining us for the first time. And so for those people that are here for the first time, just to reiterate, the real aim around the whole WebEx series so far is to support the learning and sharing between boards regarding reducing medicine's harm across transitions, considering everything from a whole system perspective. So we really want to focus the questions around what is our theory for improvement and what tests of change have boards undertaken to really drive that improvement to make things more reliable. And over the past 10 months, we've heard from a number of boards. But before we move forward, I just wanted to kind of reinforce the fact that if you're not presenting today, your phone line is going to automatically be on mute. So we really, really do encourage you to use the chat box as a way to communicate with us today. So if you do have any questions at all, please feel free to write them in and send them through to the chat box, because my colleague Catherine is going to be monitoring that today to pull out the questions at the end. We're also going to be giving you an opportunity at the end of the presentations from Lothian. We'll open all of the lines and you'll be able to have some open discussion, again, for any questions that you do might have to be asking our presenters. So please do use the chat box. Encourage you to, again, introduce yourselves, let us know where you're calling in from, and if you've got other people in the room, that'd be fantastic. So for those that have not used the chat function before, please do select the chat icon, which is at the top right of the screen, and make sure that you select all participants from the drop-down menu. There is ability to chat privately, but we do encourage any conversation you do with something that everybody can see and share with you. And as we've mentioned before, this WebEx is being recorded, and we'll make this available on our website at the end, potentially by the end of this week. So medicine's reconciliation is supported by a national driver diagram, which is really our theory for improvement. And I'd encourage everyone today, as you hear from NHS Lothian, to think about what their improvements might be linked against. Some of our primary drivers being person-centred care. Are we dealing with leadership and culture? Or are some of the activities that they're going to be sharing today really focusing on the importance of teamwork, communication and collaboration, really to then support the effective, safe and reliable care? And maybe there are some issues around systems and IT infrastructure that they might touch on as well. But equally asking yourselves, how does that relate to where you work? And I would encourage for people who have not had a chance to look at our driver diagram, it's freely available on our website. So for those that were with us last month, we heard from NHS Highland, and it's fair to say there was a really, really strong message around the importance of systems thinking and looking at process mapping and to support some of the work they're doing, particularly in the community pharmacy section. And they also were able to present a unique approach of testing My Medicines wallets in the context of involving patients in their own medicines management. And again, the recording of that WebEx is available on our website. So without further ado, I'd like to pass over to our colleagues from NHS Lothian, and I'll pass over first of all to Gillian Fulton, and I'll ask Gillian if you wouldn't mind introducing yourself as well as we start the presentation this afternoon.
Hi everyone, can you hear me okay?
Indeed we can.
Great. My name is Gillian Fulton and I am a Band 7 pharmacist working in acute medicine at the Royal Infirmary in Edinburgh. And just to kind of mention, certainly in Lothian we have been collecting data across the whole system, but today I'm just going to talk about some of the work that we've been doing in the acute adult setting at the Royal, and particularly around discharge. In acute medicine, we have been collecting data on admission since around 2008, and I think it would be fair to say that we've had quite a variable journey over the last few years, and you'll certainly see that in our next slide. And I think this is mainly due to key individuals perhaps moving on and losing some of the momentum that we had gained. Just to give you some context, our medical admissions unit is one of the busiest in Scotland, with over 80 admissions every day to just a 46-bed unit. So our average length of stay is only about 17 hours, and we do have a very high turnover of medical and nursing staff. We then have two 36-bed general medical wards, and they have an average length of stay of around 5 days, but we do have a lot of kind of longer stay complex patients as well, and also ICU step-downs. We've got really fantastic pharmacy technicians, and they do MedRec, but they also look at every single set of notes first thing in the morning each day, and that's to help us identify our high-risk patients and to prioritise who actually needs seen by a pharmacist. We've got a technician to pharmacist referral tool, and also a pharmacist triage and coding system on track based on clinical risk and when we need the patient to be seen again. We do have ECS MedRec embedded within TRAC, which has significantly kind of increased our use of ECS, but I do think we have perhaps become over-reliant on it as a source, and that can certainly cause different problems. Our MedRec paperwork in UPR is also outdated and kind of no longer really fit for purpose. We do ask doctors to staple the completed ECS into the UPR, but in reality this kind of rarely happens, and often the ECS can be hard to find. We also had an OPA inspection in August of this year, and this highlighted our MedRec processes and structure as a priority area for improvement. So this slide shows our overall compliance with MedRec on admission in our admissions unit, starting in April 2011, I think, when we started entering data in quids up to July of this year. And I think it's quite interesting to see the peaks and troughs in the data, and you can really see that where we have possibly taken our eye off the ball a little bit over the last couple of years of collecting data, our performance has reflected this. In terms of our more kind of recent journey, I attended the FPSP Medicine Safety event in Glasgow earlier this year, and I was really inspired by a lot of the great work that was being done by kind of others and other health boards. So this really gave me the drive to kind of take a more proactive approach within my own area, and also apply for the fellowship, which I started in September of this year. Kind of on the back of the medicine safety event, we also decided as a board to set up a Lothian-wide Safer Medicines network, and this was to try and promote a kind of a more collaborative approach to our working, to share ideas and really try and kind of get us thinking about the whole system. We're also in the process of re-establishing some site-wide MedRec groups to feed into the Safer Medicines network, and also the ADTC. So I think really for us a lot of the work at the moment is really kind of going back to where we possibly were 2 or 3 years ago, and kind of trying to take things forward again. We do have consultant and pharmacist-led teaching, but this is something we're planning to look at going forward and see how we can perhaps do things a bit better in that front. In acute medicine, we've increased our data collection from collecting data in 20 patients per month to collecting and reporting in 10 patients per week. And this has really given us much more dynamic data, and it's actually been a really positive step for us as a team, and given us a lot more ownership of our own data. So we're now collecting data on admission, transfer and discharge in acute medicine at the Royal. So we started our project looking specifically at MedRec on discharge, and when I was looking for examples of good practice, this WebEx forum really was the first place I looked. So I just wanted to thank David and the other health boards for this really kind of fantastic resource. I also wanted to mention the Specialist Pharmacy Service Best Practice Resource and Toolkit, which is just on the right of the screen there. For those of you who may not have seen it, it's endorsed by the Royal Pharmaceutical Society, and it's got a lot of really great links, not just resources in England, but also in North America, Canada and Australia, so it's a really good place to look for ideas if you're looking for inspiration. And I think for us as a board, kind of going forward, and very much with the project that I'm involved in, it's about kind of going back to basics with CMO letter and doing a bit of a gap analysis and just kind of seeing where we're at and what we need to do to try and take things forward. I have included the MedRec driver's diagram for this project. I'm not quite sure how clear that has come up on your screens, but I think that was some of the feedback from previous WebExes that would be useful to see this kind of thing. I just wanted to kind of mention that this was not something that I found easy to do, but I found it a really helpful exercise just to kind of get me to think really through the problem, and it really made me see how dependent on people the success of the system is, and you can see that by how many kind of arrows are going into that yellow section in the middle. So the project aim is for more than 80% of patients to have their medicines accurately reconciled on discharge, and this is from a baseline median of 27.5%, and to reduce the error rate by 75% from baseline, and this is from a baseline of 250 errors per 100 patients, so an average of 2.5 errors per patient. So the primary drivers for the project around kind of building that kind of quality and safety structure, around kind of that highly effective and collaborative team, developing systems, and of course around the kind of person-centred care and empowering patients to manage their own medicines. It's worth mentioning that we did a kind of a brainstorming exercise about where we're going wrong with MedRec and discharge, and the two most common reasons kind of unanimously given were around poor MedRec on admission and also about kind of lack of knowledge and understanding, particularly from junior doctors, about what MedRec is in general, and particularly around MedRec and discharge. So that gave us a really good starting point for where we kind of needed to go. We then used the driver's diagram to kind of generate discussions within the team, and did a prioritisation matrix just to kind of look at our change ideas in terms of benefit and effort and get an idea of what our quick wins might be, and also what was definitely worth doing but perhaps was going to take a bit more effort. So we decided our initial priorities going forward was around kind of updating the IDL template, which we originally thought would be a quick win but is perhaps kind of a little harder to do in practice, making the LearnPro module compulsory for all new junior doctors working in acute medicine, and that we have started just this month, improving our induction training, and I think very much the kind of focus of this project going forward is around improving the structured documentation and communication of medicines information from admission right the way through to discharge. When I was shadowing junior doctors who were writing IDLs just to kind of get a better idea of what was going on, I realised kind of how hard it was for them to find out, one, what changes had been made to medicines, and two, kind of why those changes had been made. So again, this was something that we wanted to kind of really focus on going forward. So this is a medicines management plan that we've put together, which started off kind of life as a sticker in the Cardex and has evolved into this plan. So just kind of running through it, it starts off kind of stating what we expect of them in terms of the MedRec process and admission, and then captures some of the information around insulin and warfarin that is often difficult to get from the ECS. And it then gives us a kind of formal place for documenting any MedRec discrepancies admission or any prescribing issues at all that need review, and then captures the changes to medicines and the reasons for these changes. I read an article that said that a patient over the age of 65 had a less than 10% chance of going home on the same medicines they came in on, and there's an average of 3 changes per patient. So I think it's really important that we capture this information better to reduce impact on primary care and obviously allow us to communicate this information to patients. So the form has been designed to sit with the Cardex rather than with the notes, and with the ECS, and this is really so the information is easily kind of accessible to everybody on the ward rounds and at the time that it's needed when the IDL has been written or clinical decisions are being made around medicines. So we are just at the very early stages of testing, but there are a couple of things that I just wanted to mention from a test that we did in our admissions unit last week. 100% of patients had a plan documented for each medicine, and this is fantastic. I don't think that's something we've kind of ever managed to achieve before. And also 80% of patients had changes to medicines correctly documented in the form at the time of review and admission, before pharmacist or kind of technician intervention. So again, I think that's really quite a promising kind of step, but there is a long way to go in terms of reliability of use and certainly communication. In terms of our discharge data on Ward 27, I collected 10 weeks of baseline data, and I've just started to make some kind of changes over the last 4 weeks, So it's kind of very early stages for us, but hopefully we are kind of starting to see some small changes coming through in our data. We started filing the ECS in the Cardex rather than in the notes, We've been testing the medicines management plan at ward level, and I think kind of what's been a bit of an eye-opener for me in particular is I've actually stopped correcting errors myself as a non-medical prescriber, which I think was something I kind of did to make my own life better and kind of easier. It was just easier for me to correct the changes, but actually giving that real-time feedback to the doctors I think has had a really positive effect. It's worth mentioning at week 10 there, the ECS was down for a whole week, which was a bit of a disaster, and you definitely saw the impact of that on both our admission and discharge data. So just kind of breaking these things down, the kind of list of medicines and changes documented have both been kind of consistently above baseline for the last 4 weeks, which is really quite promising, and potentially some improvement there in terms of our allergies being accurately documented. So in terms of the overall compliance, hopefully we are, as I say, starting to see some change coming through and perhaps some kind of special cause variation. I had originally wanted to collect potential risk of patient harm as an outcome measure for this project, but I didn't really feel the data was perhaps telling us enough. So I started collecting data on error rate instead a few weeks ago, and it just seemed to be a bit more sensitive, less subjective, and I think it's possibly telling us a little bit more than maybe some of the other measures we're doing. So in terms of our successes and challenges, I would say our main organisational success has been around kind of development of that Lothian Safer Medicines network, really kind of helping to build that culture for safety and quality and encouraging us to have a more collaborative approach across Lothian. In terms of the discharge project that I've been working on in particular, I think the multidisciplinary engagement has been really fantastic, particularly from the consultants. I would say I've got 4 really engaged consultants on board with the project, as well as a fantastic pharmacy team, nursing team. I've got a nurse wanting to do her management project on this work, and also a 5th-year medical student, so all really positive. But I think one of the main things is actually feeling empowered to own our data and to do something differently, and that's been a really positive step, not just for me, but I would say for the whole team. In terms of the challenges, I think like most boards, it's around that kind of sustainability and spread, around sharing our data. The measures and quids unfortunately don't reflect the CMO letter, and certainly collaborative working within our own settings, but also kind of across interfaces as well. But I think our kind of biggest challenge in Lothian for us is the fact that we don't have a formal MedRec policy that gives that kind of clear structure and defines roles and responsibilities. So I think that's definitely something that we will aspire to going forward. So, kind of key points for sharing around some of the track template work which Ilsa will go on to talk about. Medicines Management Plan, we would love to know more about the NES Learn Pro module, and if any other boards have made that compulsory for junior doctors and any success with this. Also around kind of reliability of communicating changes to medicines to patients, and particularly from boards that operate a one-stop policy, we'd love to hear about that. And any other boards that have actually involved patients in kind of MedRec working groups and any successes with that. And I wanted to include this last slide just because I think it really kind of does reflect kind of the work we're doing with MedRec, and I think success really will come from doing kind of lots of small things in a great way rather than doing kind of individual big things. And that's me. Thank you. I'll pass the ball back on.
Thank you very much, Julian. Are you happy to pass the ball then?
I think that should be it.
That's brilliant. Thanks very much.
Thank you.
We move on to our second presenter from NHS Lothian, and I'm just going to pass the ball to Elsa. Can you just let me know that it's come through?
I think that should be fine. Thank you.
Thank you very much.
Hi, so I'm Ilsa Howe. I'm one of the acute medicine consultants at the Western in Edinburgh, and we have a couple of people that helped with this presentation, so I should say thank you to them as well. Eleanor Morrison, who's here with me today, and Claire Gordon, who's one of the doc consultants, and Sandra Nash, who's one of our pharmacists. So I thought I'd do a little bit about where we've done with our MedRec on admission and the challenges we face with that before going on to the main bulk of what our new project is. So we unlike the Royal Infirmary, we've moved to a paper-light system, which means that we don't write on paper anymore. So we have to do our medicines reconciliation as part of our generic Clarkin document on the computer. This has brought lots of challenges to us to try and find ways to remind the junior doctors about the elements that are required for this. So earlier this year, we developed a / code, which is what we use to bring up kind of predetermined text into the system, and we've got a / medrec which basically brings up what you see on the screen into a template box, which asks you to delete the relevant sources or keep the sources that you use. It also highlights the importance of including the medicines, their dosages, their frequency, the route, and really very importantly the stop, hold, continue. We're also again very keen to remind our junior doctors about over-the-counter medicines and the recreational medicines that they might not have asked about if not prompted. We again, same, have been collecting data for quite some time, and I think as Gillian said, the changeover of doctors and nurses and pharmacists does impact on how that happens. We made a very positive step last year when we started putting a push on it around about November time and got one of our pharmacists to take over the data collection, not to put doctors down, but often we're not quite as particular about it when we do it, and often weren't looking at things in probably as much detail as the pharmacist was doing it as well. The interesting part about that is I now have a very reliable way of the same person collecting the data, so I know that there isn't any bias or any variability with the result of that, which is often one of my things I thought when different people were collecting it, when junior doctors changed over or a different person took on the project. I don't have to rely on that. Obviously, you can see our variation, and I've highlighted that our junior doctor changeover does seem to plummet. Our total compliance with the admission MEDREC. The short code induction came in June this year, and we had seen a bit of improvement, obviously, until junior doctor changeover. What I can tell you is I decided to go and do a small MEDREC audit with one of the pharmacists today just to see where we were, because we didn't have December's data yet, and actually we've seen that with the junior doctor changeover and teaching them again as the day they started, I've seen a massive improvement from the two doctors in particular that were taught by myself. We've got a 40% overall compliance just now. We've got the list, so if I show you the breakdown of each bit, the green lines are a list of medicines in our UPR. We've then got the purple being our stop, hold, continues being documented, two sources in blue, and the list marching the Cardex in red. That was November data. As of today, our list is up to 80%, our two sources are up to 60%. Our stop, hold, continue is still not good enough, but 45%, and a list matching of 70%. So I think we have seen a slight improvement over the last week, particularly with changes of doctors and trying to influence this and basically not letting them find another way around it, teaching them this is the way we do it. With regard to our new project, we found that we want to try and improve the discharge profile, and I went to see a presentation when I was at the Six Essential Actions workshop, and Paisley and Ian Keith presented on what they'd done to try and improve their discharge IDLs, and it looked so impressive. I came straight back and started trying to do stuff to try and improve ours. So basically, I listened to what they said, I learned what they thought, I had a chat with their team. We realised we were doing something very similar in our, we call it trolleys area, but it's a kind of medicine admissions area, but we take 999 ambulances as long as it's in a GP, and it's a bit more like A&E than anything else. So our proposal was that in the acute receiving unit, our bedded area, so once you'd been actually admitted, we would implement a new, what we've called abbreviated IDL, so immediate discharge letter, for all patients who've been an inpatient for less than 48 hours with less than 4 medication changes, 98% of the time. So we wanted to know what the potential gain would be for doing this, and over the course of a weekend, we actually got data for every patient that was discharged, and one of the pharmacists went through it. So we had 19 patients who were discharged directly from the receiving unit within 48 hours of admission. 21 medication errors were found in immediate discharge letters, and had we used an abbreviated IDL, it was felt that 20 of these were avoidable, something that I think is quite spectacular. Many of that was due to medication that should have been prescribed not being prescribed. We also found that 11 patients out of the 19 would have met the criteria to have an abbreviated IDL. We did however find that some of the paper notes were missing, so there were 6 patients that were discharged then that we didn't have information or all the information for. So I think what it said to us was that by using an abbreviated IDL, we may reduce the vast majority of our medication errors. We've also given you our driver diagram, which is by July next year, working towards having an abbreviated IDL for all patients who have been an inpatient for less than 48 hours with a maximum of 3 medication changes, greater than 98% of the time. Our real primary drivers were about improving the speed and efficiency of our discharge process, making certain that the patients had safe, effective care for discharge, and improving the accuracy of our medicines reconciliation at the time of transition of patient care. There are a couple of different elements to that through there, and many of it is again looking at similar areas that have done the same project, looking at errors in the IDL, looking at the time taken to perform an IDL, and looking at the flow and the impact it has, not just on the doctors, but also the nurses and the pharmacists. So really the reason we wanted to do this is to try and reduce the errors and speed up the production of our immediate discharge letters, and I've got some data on that coming up. We want to reduce, again, errors to give less adverse incidents for the patients and for us to have to follow up. And again, to try and improve staff morale, there's nothing worse than being told you've made a mistake and having to look into it. We wanted to reduce opportunities for errors in MedRec, and again, that was about not having to write every single medication down. And also about trying to make it better and easier for the patients and carers to be able to follow the letter, because all it would document were medications that were changed rather than every single medication they were on. We hope that that would then make it easier for the GPs to try and change their emergency care summaries, because again, they would only be looking at medication changes. And hopefully, by increasing the speed at which these discharge letters can be completed, then we would find that our pre-12 discharges would improve, and as we know, that improves our compliance with the 4-hour standard for our receiving unit. So again, questions that we wanted to look at were, what are the errors that occurred and how could we avoid them? How often do they occur? Looking at how long it takes to do an IDL. What is the effect of poor MedRec on admission and the effect that this has on our discharge process? What is it that we do on discharge and how valuable is this for not just the patients but the GPs and our junior doctors? So we looked at a year's worth of data from Datex telling us the kind of errors that happened, and there were 12 types of errors that occurred in our discharge IDLs. Missed doses and things not prescribed, errors with MedRec on admission, missed doses, changes of drugs that didn't appear in the IDL, allergies not documented, and errors in medications on track. More importantly for me was about how long does it actually take one of my junior doctors to write a letter to allow a patient to go home. We have the computerized system, so actually we are fairly dependent on that now, and if that fails or slow, and that can happen quite often, our time to perform an IDL can be as much as an hour. Some of that, again, is being interrupted by the nurses telling us to go and see sick patients or to perform some other task or doing other things that need to be done that are seen as a higher priority at that time. However, even looking at that, our average time to write an immediate discharge letter is up to 28 minutes. And even when you take out the 2 outliers at 60 minutes and 65 minutes, it's still up at 25 minutes. And if you're discharging many patients a day, as we are from our receiving unit, this all takes time. So we asked our pharmacists to have a look at our medicines on discharge for 1 week and look at how our compliance was like. So we saw that we were 90% compliant with inpatient discharges to medications being documented, 75% compliant with our correct med list on the IDL. That means that letter is going back to our junior doctors 25% of the time to be rewritten and re-amended. The meds on the IDL have the correct name, dose, frequency and route only 65% of the time, which gives us overall compliance of 65. And each of these times this is identified, our junior doctors are having to amend this, which involves logging into the computer, uploading it on the computer system, and then finding a computer that will print it out. So to try and improve this, we designed the abbreviated IDL. So our track system, when you log into one of the communication boxes, you can put a /48 IDL and a space bar, and it will bring up what is our own, and the same as the Royal Infirmary's, immediate discharge letter for all sites. However, what we have at the top of that is a section which basically, I know it's quite small writing, but will basically say to the GPs that this is an abbreviated IDL as part of a quality improvement project. We will only be documenting medications that have changed. That includes starting, stopping, changing doses, changing frequencies, and it can only be 3 medication changes that are made. We've given them, as part of a safety brief, really that, but also given them 3 contact names that they can contact any time of day, and we've given 3 names because we felt that meant even if one person was off, somebody would be looking at that. We've been in contact with our GP colleagues. I've been to a couple of meetings to try and ensure they were happy with this, to make sure they were happy safety-wise, that by just writing our medication changes, that they wouldn't worry. And the feedback from them was that they often worry when something isn't on the list. Did we change it on purpose or did we just forget to document it? But with this system, they'll know that we've only put down the things we've changed rather than anything else. So the hope is by doing that, they'll find it easier. We'll find it easier to complete and faster to complete the form, and the pharmacist will again be looking at that. There were concerns that particularly out of hours, if the pharmacists weren't checking our discharge letters, that there could be errors made. However, in our kind of front door kind kind of more acute area, we're sending people home with just the medication changes documented there already, and there's never been issues with that, in terms of safety issues being raised. So the hope that this is not going to be an issue. However, it will be checked every single day by a pharmacist, and anyone discharged out of hours will have their form checked the next day. As a result of this, we will not be running this project over the weekend, so it will stop at 4 o'clock on a Friday, because we felt that leaving it over the course of the weekend without reviews while doing a test of change was maybe not as safe as it could be. However, the plan would still be to run it 7 days a week, 24 hours a day in the future if we can prove that this works. So we've obviously got the code. The track template was completed yesterday, so my job now is to get the information out to GPs. We're going to teach our junior doctors tomorrow, and our plan will be to run live at the start of January, where hopefully we can try and speed up our process, because as we all know, first week in January we'll be all pretty busy in terms of acute admissions. We've also had support from our nursing staff and our pharmacy staff with this, and hopefully we will be able to help medical staff complete the agreed process with no misinformation, and again helping try and streamline the process for carers and patients to understand the letter that actually leaves with them. Like I said, our next step is really on about getting the project started and making sure we've got our data collection, developing the training material, and assessing the impact that this has on everyone. So our junior doctors, how long does it take them to complete the form? Our nurses, does it affect the time it takes them to check and counter-check the discharge letters? And our pharmacy staff. We need to collect feedback from all these people, including our primary care colleagues, to make sure there's no errors that are occurring that we need to know about and we need to change, and also patient comments. And we need to compare and contrast our pre and post data once we get it. So really, again, success, we need to be sharing our successes and sharing our work with other specialties within our board, and also with our board if it works. We need to work collaboratively to consider all members of the team and the impact this has on the service, not just the doctors and pharmacists, but also our nurses and our patients. And we need to make sure we're enabling staff to work safely and focusing on our patients. Challenges for us, again, very much like Gillian said, it's about a constantly changing workforce and making sure that our patients, that our doctors are up front and up to date with everything we do and all our backslash codes. But again, I think, as we've mentioned, that can be challenging during induction when they've got 25 other things that everybody thinks is the biggest priority. Again, competing priorities at the front door environment, making sure that the safety things are done. Compliance from the clinical staff, and as I did from looking through the notes today, I've got doctors that do it right 100% of the time. I've got doctors that do it right 75% of the time, and I can assume sometimes that's just because they're so busy. And I've got doctors who just aren't as supported as they could be, and they're the ones I need to focus on. I've tried chocolates, and I find that often helps, particularly when you identify the person who does it the best, not liking the one that does it the worst, but everyone quite likes a box of chocolate. And it's all about sustaining the change again, so making sure that if this change does work with regard to our discharge ideal, that we can sustain the change when it's not necessarily the 100% focus. And if we've moved on to our focus, we need to make sure that that still remains a priority. So for us, key points, we need to analyse our systems. What do I need you to do? How can you help me? Who can help me achieve this, and how can we make it safe, and the other kind of things we've looked at. But again, we're very interested to know what have other boards done in MEDRC, how do others see the management of MEDRC in the future, and I think again, how can we influence supporting systems such as ECS and making sure all the drugs are on it. I see from one of the questions there that I totally agree that we are missing medications that just don't appear on our ECS, and also the key information summit is incredibly important to all of us. So again, I think this is just all about trying to make things safer, most for our patients, but also making sure we're making the job as easy as we can for our junior doctors to allow them to make sure they get the right drugs out to the patient first time, rather than being asked to recomplete discharge letters 25 times, which again should reduce the workload on our pharmacists, who shouldn't have to be asked the junior doctors to make so many changes. Thank you very much. Well, I hand the ball back to you, David.
Thank you very much. That's fantastic. So Alva and Gillian, thank you both for presenting what I think has been a really interesting presentation. I think also a reflection, quite an interesting two different approaches within the same health board, so lots of opportunities for learning in terms of going across sites and then across boards. So thank you both very, very much. As we've been going through, there's been quite a bit of chat in the chat box, and I do apologise in the fact that as the request to select all participants when participating, I know there's been some chat that has been going to all attendees, and unfortunately the panellists cannot see that chat. So if we do miss anything, I apologise. but we do have quite a bit still coming through in the all participants chat. So if we can go work our way back through, I think there's been a lot of interest, Elsa, particularly around the abbreviated IDLs. And I don't think that was going to be any doubt around the interest in this. And I think if we can just go back up to a couple of points, and I think it's the first question that we had really, I think, is around safety and completeness, which I know you've touched on. But I know that Pamela has asked that she's interested to learn a bit more about the abbreviated IDLs. How do you ensure that important drug interactions are not missed? And I guess building onto that, the question I think is directly linked to that is when you were talking about for medications that only the medications that have changed is the thing that you'd be interested in, but compared to what I think is one of the other questions I've seen in terms of, is it compared to what's in the ECS? Is it compared to what was reconciled at the point of admission? Would you mind expanding on that just for a moment?
Yeah, no, absolutely. So I think, this is obviously one of the things we had, and had lots of discussions with our pharmacists about this, to make sure there weren't going to be interactions missed. We now have pharmacists 9 to 5 every single day checking all of our discharge scripts and all our patients' MEDRIC, even after the doctors have done it, which has been a massive improvement for us, identifying these interactions as they occur. I suppose I would be hopeful that we wouldn't be missing many interactions. I think we do the same thing in our trolley area where people go home and all we document on is a paper script of medication changes that we make. And so the hope would be, again, at that point in time, we've not had massive things highlighted to us that we've started people on medications that have caused significant interactions. And that's, again, why we've not been running it over the weekend, because we felt that until the project was fully embedded and we were happy that our systems were reliable, 24 hours it's going to take for our pharmacists, or less even, probably 12 hours for them to check our discharge letter to ensure that we haven't made any interaction mistakes. Most of our patients will have an admission assessment by our pharmacy or pharmacy technician to make sure that all the medications are documented. We've got a pharmaceutical care section to our admission document where the pharmacists document any changes that we haven't identified fully on admission, to make sure that they're all up to date, and they will highlight to us any changes that the Cardex requires that we haven't seen already. So the hope is that those patients that have been in for that length of time, so anyone that's been in probably more than 12, maybe definitely 24 hours, will have had their medications assessed by a pharmacist or pharmacy technician to try and prevent these things from happening.
Thank you.
Does that answer the question?
So Kate, would you mind opening the phone lines, please?
Certainly. Would you like to go to a structured Q&A, or would you like everybody's line open?
If we can just do all at the moment, and we'll just ask people to ensure that they're quiet if they're not speaking, if that's okay.
Certainly. It'll just take a few seconds. Bear with me.
Thank you. So, Elsa and Julian, I just want to give the opportunity to open up to the floor. I don't want to misinterpret anybody else's opinions or responses to the question and answer. So, with Kate now opening the lines, it means that everybody will...
Now.
Thank you. So it does mean that we'll be able to hear everybody just now. So can I ask that you do try and either put your phone back on mute if you've got nothing to say, but if you'd like to participate, please do. Pamela, does that answer some of the questions that you'd raised in terms of the drug interactions and
I suppose we're in a fortunate position here in Ayrshire that it is actually very easy to put everything on the discharge letter. So certainly I would still be concerned that if somebody doesn't actually see the whole list of medicines, that there are potential things that will get missed. And also for changes, we sometimes change things, but we haven't because we didn't actually have the right information at the start. So to actually tell the GP what you've changed might not actually be a change. So I suppose from my point of view, I'm just a bit concerned about the abbreviated immediate discharge letter from a safety point of view.
So Pamela, can I just check, when you said it's easy, is that, I don't want to assume, is it because you're working in a fully electronic environment?
Yeah, because we've got HETMA, I mean, literally anything that you want to put on the discharge letter, it's very just tick, 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 or not tick. So it literally takes seconds to actually do.
Okay. So I guess, Elsa, what this does confirm, I think there's a lot of interest in terms of the outcome of the testing work that you are doing with the abbreviated IDL. So can I just call across to Rachel? I know you mentioned in the chat box that there's some testing happening in GGNC as well.
Hi there, am I off mute?
Yes, you are.
Yeah, that's fine. No, I know I think in the REH they were doing some testing, but they were only doing it, my understanding, on kind of specific patient cohorts, so patients that had been in sort of for less than 24 hours and there weren't really any kind of major changes. Is that the same here? Is it under, you know, is it just specific patient cohorts that you're doing the abbreviated IDL on, or is it wider than that?
No, it is absolutely focusing on the work done by Ian Keith in Paisley and following on from his work, the same sort of thing. So it is only patients who've been in for less than 48 hours with less than 4 changes, and a change is documented as any drug that's started, stopped, dosage changed, timing changed, anything like that at all.
All right, okay, that's great, thanks.
Thank you. And this is where it is a bit potluck. I am going to go to people's names that have put things into the chat box, so apologies if you didn't expect that would happen. Anthony, Carsten, you've asked a specific question around people using the GP patient summary on Clinical Portal for performing MedsRec as opposed to the emergency care summary. Did you want to expand on that question?
Yeah, that's something we've started to look at. We only had access to this granted about 2 months ago in Lanarkshire. I'm not sure if this is something that other people have seen, but this appears to be potentially a slightly more reliable source of information as opposed to emergency care summary. But we're doing some sort of pilot work at the moment to see if shifting to GP patient summary would lose anything that's on the ECS. I just wondered if anyone else had used it.
So Anthony, based on our experience of WebEx's, silence usually means no. It's very rare that people actually respond unless they have been doing it. So it sounds like you'd be a unique board that we could go to learn from. So out of ignorance, from my perspective, I'd be really keen to pick up on another comment or a question that was raised around some of the non-primary care-based prescribing that's not seen on the ECS. Is that likely to be then visible or at least referred to in the GP patient summary?
Sorry, I don't know if you were going to ask me that question. I think potentially yes, it could do, because our GP patient summary seems to pull live data from the GP's EMIS system, whereas the ECS appears to be a central server where it is pulling information every so often. So potentially that might have avoided that problem if it was slightly more up to date. But as I say, we're doing pilot work, so I can't say for sure if that would have helped.
Thank you for that. So this, again, it might be something to watch out for, because certainly, and I know there was reference to the CMO letter where it's quite clear around the recommended minimum of 2 sources, and the ECS is one of those. I just wanted to pick up on the comment, and I can't remember, Gillian, if it was yourself that referred to over-reliance on the ECS as a source of information. Did you want to expand on that in terms of, because I think we've heard that from other boards, and particularly when we visited boards more recently, that there's a risk of the ECS just being put into the notes as the kind of reconciled source of medicines. Is that kind of what you were referring to?
Yeah, very much. And I think it's kind of unfortunate the way our structure is set up at the moment, that they'll just write in our kind of unitary patient record CECS. And then sometimes you can't find the ECS, or the ECS is there, but it's not actually being kind of filled in with the second source and the plan for each medicine. So I think for us it's very much about trying to kind of reinforce that process with our junior doctors and kind of going back to basics about what MedRec actually is. But particularly when we used or kind of tested the medicines management plan, it did seem to kind of perhaps help those process measures, which was quite positive to see.
Okay, thank you for that. I'm going to go to Roger, who's in the darkest northern depths of Shetland, I believe.
Yeah.
Roger, you've made a couple of comments, observations.
I'm rather croaky. I've got a cold. So.
Oh, I'm so sorry to hear that, to put you on the spot. Maybe we should keep you typing. But I noticed you had a few comments, and I just wondered if there are any particular questions or points that you'd like to raise during the WebEx.
I think the first thing to say is that medicines won't appear in the ECS or in the GP summary if they're prescribed elsewhere, unless the GP actually puts them in there. We have a primary care pharmacist in the practice I work in, and they do that. And so if they know that, for instance, substance misuse are prescribing or mental health are prescribing, they will record that. But it's I would frankly say that's probably a bit hit and miss, and so there will be gaps in the ECS information or the primary care information as a whole.
Okay, thank you for that.
The other point I wanted to make was about the abbreviated IDL. There is a slight risk that if you only record changes, there are two risks I see. One is that if an error was made on admission medicines reconciliation, that will not be apparent, because all you'll be recording is the changes you've made. But if you didn't know that somebody was on a particular drug, we'll never know that. And the other, which is a slightly, I don't know if it's left field thing, that there is a slight risk that somebody might see this abbreviated list of medicines and assume that that's all the medications that an individual's on. So if you've got an abbreviated medical discharge summary, I think it needs to be very, very clear that there are other medications that this person is taking. These are only the ones that we have changed. I hope everybody can hear my croak.
Yeah, I'm sorry that we put you on the spot with a croaky voice, but I do appreciate your contribution. Thank you. So, Elsa, is there any comments that you'd like to make in response to those?
No, absolutely. So, I mean, I think at the moment this is a work in progress. It's come from the work that was done in Paisley that seemed to have an impact. Definitely the errors that we've seen so far, that we've looked into a lot, have been errors of us missing drugs and not sending them home, and then the letters from the GPs coming back saying, did you stop this on purpose? Did you just not know they were on it? And there haven't been interactions with anything we have started. So at the moment we haven't found anything that's causing harm. But again, that is why this is very much a contained project. There's a four or five line bit at the top of the abbreviated IDL now that says this is an abbreviated IDL, this is a test of change, please contact us if you want any other information. And there's even, like I was saying, there's 3 email addresses there that will be people who will be able to identify and come back straight away, 2 consultants and 1 senior pharmacist who will be able to identify those things. Obviously, if this is tested and we find there are errors and we find there are interactions occurring, the project will be stopped immediately. But I think it's something that seemed to work in Paisley and seemed to improve their discharge profile and improve their time to discharge. So I think it is something that's worth trying. Well, in the very, very, very forefront of our minds, being aware that if errors start occurring, then we have to do something about it. And that's why the IDL specifically states contact us immediately rather than waiting to have a meeting and get feedback from people. I want to know whether there are errors occurring the minute they occur, so we can, if we have to stop the project, we stop the project.
And thank you for that honest reflection there. It's fair to say, based on the chat and the questions, there's a lot of interest in the work that you're currently progressing. So I'd be really keen that we are able to catch up with you to sort of learn how things do progress. And I think that's something I think a lot of people on the call would love to hear.
David.
I was going to say, I think it might be worthwhile, if that is the case, it might be worthwhile trying to contact Ian Case, who is the consultant who was running it in Paisley, because he's obviously a significant step further ahead than us, and he can probably give you more information about that.
Thank you very much for that. I think, Arvind, was that you coming in?
Yes. I was going to add that we've also been doing it, and Gillian, correct me if I'm wrong, we started this, about a year and a half ago or something, where we weren't typing in all the drugs. That's been on and off. Sometimes we are then told, no, you have to put them in. But we also use an abbreviated IDL, particularly from the primary assessment area, which is a GP referral area where they are assessed similar to the trolleys in the Western General Hospital. And again, in that, the wording that we use using a similar sort of backslash, the short code is changes from ECS, and it's very clearly referenced that anything that we are suggesting is a change from the ECS rather than from unknown sources. The challenge that people in the chat have mentioned that not all the drugs are in the ECS is definitely quite a big one, but I think for most of these patients, it doesn't seem to have been an issue so far. I don't know how individuals have handled each one of those cases where somebody might have come in on clozapine, for example, but the majority of patients who come in to medicine for admission and are discharged within 48 hours seem to be people who are not typically taking methadone or clozapine.
Can I add just to what Arvind has said, the system that we've got at the Royal is that if somebody's in for less than 24 hours, there's no changes to their medicines, then we don't prescribe any medicines on the IDL, they just get the letter. But that's specifically for very short stay patients in our receiving unit with no changes. So yeah, that's maybe kind of slight difference.
Thank you for that reflection. And again, there's some very interesting reflections as well coming through in the chat box, which I encourage people to make sure they read. I'm aware of the time, so I might just ask, are there any final questions before we bring what has been a really interesting and clearly engaging presentation to a close? So are there any final questions?
I would just like to make a comment about the abbreviated discharge letters as well, and I think one of the good things for me is that it's actually been recognised that it's not an easy task to do an immediate discharge letter, because I think that's often underestimated by other kind of people that's not involved in that process. And interestingly, when you're saying 60 to 65 minutes is your 2 outliers, that can be quite common for that as well. I think we need to be careful as well, though, because we are talking a lot about junior doctors, etc., and I think we need to recognise that we do have other non-medical prescribers out there who will be, you know, involved in this process. So I just think we need to have that kind of wider multidisciplinary look at things as well to make sure we're capturing everybody.
Thank you very much, Linda, and I appreciate your final comment there. So before we bring the session to an end, and Rachel, to echo your comments, can I just thank Elsa and Gillian very, very much for their presentation this afternoon. I think it's a really good focus on an aspect of MedRec that not a lot of boards have previously shared, the particular focus around MedRec on discharge. So it was quite interesting and good learning, and obviously a lot of discussion. Before we do close the WebEx, I just want to remind you, as we've said before, we've got another 2 WebExes scheduled for the end of the current financial year. So Dumfries and Galloway are next January, Tayside in February. And what I did want to also highlight, and please do go to your program managers for more information, but we're holding a Medicines Reconciliation Summit on the 2nd of March in Edinburgh, and it's for the purpose of bringing board leads and national stakeholders and national leads together to really summarise what we've learnt over the last 12 months through this WebEx series, to try and identify what are those things that are working well that we should keep doing, but equally a recognition of the challenges that a number of boards continue to face despite a lot of efforts over a number of years around medicines reconciliation. What is it that we could do nationally to try and help support boards move forward? So that's happening on the 2nd of March. Registration and teams will be managed by your SPSP program managers, and it's purposely a smaller event than normal. We're not talking about 700 people, nor are we talking about 300. We're looking at about 100 people coming together across Scotland to meet with national leads and stakeholders in this area. So please do keep out for more information. We'll keep you updated, but and contact your program managers as well in terms of once the registration goes live, which will be on the 9th of January. So without further ado, I think we've done all of our plugging that we need to do in promotion. Can I thank you all for your time? I want to wish you all a very safe and happy Christmas and New Year, and we look forward to joining you again more formally when we get together with Dumfries and Galloway towards the end of January. Thank you very much for your time.
Thank you,
David.
Thank you.
Ladies and gentlemen, that concludes your conference call for the day. You may now disconnect. Thanks for joining, and enjoy the rest of your day.